Saravanan, and I'm here to talk to you about scaling and root planing. Scaling is a process by which the biofilm and calculus are removed from both the supragingival and subgingival surfaces. Whereas root planing is a process by which the embedded calculus and portion of disease cementum will be removed to produce a smooth, hard, and clean surface. So what are the principles of scaling and root planing? So the primary objective in scaling and root planing is to restore the health completely by removing the factors which are going to provoke inflammation. So scaling should be not viewed as a separate procedure unrelated to the rest of treatment plan. Careful analysis of case, number of appointments needed to complete is estimated. So small amount healthy tissue can be treated with one appointment. The dentist should estimate the number of appointments needed depending on the severity of the mouth, inflammation, calculus, any furcation, as well as compliance of oral hygiene. So how do we actually detect calculus? Basically, calculus can be detected by an accurate initial examination, like we can see visually for supragingival. However, when you're checking for subgingival calculus, it would be difficult to visually assess. So we might have to spray a direct air into pocket. But the main thing is we use a tactile perception where we use the explorer below the gingival margin where the calculus will be detected as irregularities. So this is basically for subgingival calculus. So after a stable finger rest, tip is carefully inserted and then light exploratory strokes can be used. So when it's encountered, the instrument should be advanced apically over the deposit until the termination. So the apical edge of calculus and bottom of pocket usually ranges between 0.2 to 1 millimeter. So the tip is close to the tooth to ensure greatest degree of tactile sensitivity. The most important procedure is in periodontics is a supragingival scaling. So this is essentially for removing the less tenacious, less calcified calculus. Sickles, curettes, ultrasonic, sonic instruments are used. The sickle or curette is held with a modified pen grasp finger rest to establish on the tooth adjacent to working area. The blade is adapted with angulation slightly less than 90 degrees, the surface being scaled. The cutting edge should engage the apical margin of supragingival calculus with short, powerful, overlapping scaling strokes, which is activated coronally in a vertical or oblique direction. Subgingival scaling is usually harder. When you compare subgingival calculus, it's usually harder than supragingival. So vision is usually obscured because of bleeding, and hence, in addition, pocket wall limits the direction and length of stroke. So the curette is a preferred instrument for scaling, especially in the subgingival areas. So what is the main difference is that it has a curved blade, a rounded toe, which allows it to be inserted to the bottom of the pocket, and then we can remove the calculus. So sickles, hoes, files, ultrasonic instruments are also used for subgingival. Small files may be inserted to base to crush the deposits, but however, it's easier to remove only with a curette. So as calculus is removed, the resistance to the passage of cutting in diminishes. So longer, lighter root planing strokes is activated with lateral pressure. So scaling root planing stroke should be always confined to that portion of tooth where there is calculus and altered cementum. So this is known as instrumentation zone. This is a very important viva question. So the sweeping of the instrument over the crown where it is not needed, base operating thumb dulls the instrument and causes loss of control. So if heavy lateral pressure is continued after the calculus is removed, then has been removed and the blade is readapted short strokes resulting in roughened root surface. So heavy lateral pressure is continue long, excessive removal and ditching. So to avoid the hazardous root, powerful strokes will be lighter root planing stroke can be used. So this is how you flush it into the subgingival area. It's inserted with a 0 degrees angle. Then you can very well see that the blade is establishing a 45 to 90 degrees angulation. And then you apply the pressure and remove the calculus in an upward direction. So various instrumentation zones. So this is a maxillary area where we can see sight position, visibility, direct, and mirror index finger of non-operating hand. Rest will go extraoral and palm up. Whereas posterior back, when you're doing it on the posterior areas, can be side or back, visibility direct. Retraction can use a mirror or an index finger. Rest would be intraoral, palm up. So fourth finger on the occlusal area. This is the right posterior. On the lingual aspect, mainly you can be front side. It's indirect or direct illumination. Visibility is again indirect. You don't require retraction. However, this again it will be extraoral, palm up. For anterior maxillary area, you can come in the front, direct light. You can retract with index finger, and it can use an intraoral finger rest. For a posterior, again, we can use either the back or side, and then direct, indirect, and it's an intraoral palm up. And then maxillary posterior aspect lingual area, we can use a front position, no retraction required, intraoral palm down technique. Then lingual aspect, again, we can use a front position as well as we can extraoral palm down. So maxillary left posterior lingual can also use an intraoral occlusal surfaces. Then mandibular anterior segment, you can usually use a front portion, direct vision. If the mandibular facial aspect, we can use a index finger or thumb of the non-operating hand, and also we can operate from the back position. And in the mandibular, if you're operating on the lingual surfaces, we can use a back portion, indirect vision, and intraoral rest can be used. Then again, you can operate also from the front position like this. Then mandibular posterior facial aspect, we can operate from the side of front and middle index finger of non-operating hand. Mandibular posterior lingual aspect, again, we can from the front, direct or indirect, and the intraoral palm down rest. So going to ultrasonic instruments, it's usually the only method available for safe removal until it was introduced in ultrasonic were introduced in 1950. They are power driven, machine driven. So the high frequency ultrasonic or air pressure sonic. So various factors would include frequency, stroke, water flow, in addition to flow, physiologic effects of water. So the power scale, a sonic usually frequency of 2000 to 6500 cycles per second. Whereas ultrasonic piezoelectric magnetostrictive requires 18,000 to 15,000 cycles per second. So these they have been shown to be effective as hand instruments. Slight rougher surface, lesser time effective for areas where there is narrow areas where it's usually not reached by hand. The power instruments are used non-surgical therapy, but they are valuable aid to remove the residual granulation tissue where it is difficult. So usually frequency 25,000 equates to tip 25,000 times per second. Whereas active, it's active, and to remove hard soft deposits, smaller active areas, insert the tip would be inactive. So we should never put too much pressure. So usually the stroke is a maximum distance it travels in one cycle of stroke, and amplitude half the distance of the stroke. Power knob of ultrasonic controls the length. Increasing power knob increase the distance. So high power settings produce a longer stroke, lower short power stroke. So generally water is always directed, and it's tuned 3 knobs which could control the movement of water. Sonic and ultrasonic, as we've already seen. The ultrasonic further magnetostrictive piezoelectric. So sonic they are high speed, low speed. Water is delivered through same tubing and allows it to be adapted. Piezoelectric is handpiece. They change the dimension of electrical handpiece. That moves. Magnetostrictive is metal stacks that are applied power using a magnetostrictive technology, and the vibration travels metal stock to the connecting body. Tips is mainly in the elliptical motion, mainly supragingival, subgingival scaling, removal after orthodontic treatment, orthodontic cement, and then as well as surgical interventions, as well as removing the overhanging It's not indicated in pulmonary diseases, asthma, emphysema, cystic fibrosis, pneumonia, cardiovascular disease, unshielded pacemakers, and dysphagia. So in conclusion, scaling and root planing is one of the most effective ways to treat gum disease. So proper instrumentation, chair position, as well as the procedure will help in the removal of all